Good afternoon. I'm Dr. Kay Wilson. I'm a postdoctoral research fellow and co-convener of the Disability Law Network here at Melbourne Law School. And I'd like to warmly welcome everyone here in person and the many people who are online to the panel discussion today about a very important topic, stigma and discrimination in mental health. Something which really pervades the mental health system and every area of life, and has recently been the subject of a national strategy by the National Mental Health Commission, which hasn't yet been released. And I know from my fellowship research that stigma and discrimination are also important social determinants of mental health. Before we begin, I'd like to acknowledge the Wurundjeri peoples of the Kulin Nations as the traditional owners of the land on which the law school stands, and to pay my respects to their elders, both past, present and emerging. I'll now introduce the stars of this seminar, our wonderful academic and lived experience speakers today, because time is tight and I'm keen to get started. And I'm going to be very brief. So they all have absolutely amazing CVs, and there's detailed bios for each one on our invitation for this event and on the website. So first, our moderator, Emeritus Professor Bernadette McSherry from Melbourne Law School. She was also the Foundation Director of the Melbourne Social Equity Institute and a Royal Commissioner for the inquiry into Victoria's mental health system. Now for our panel, Maria Katsonis is an industry fellow here at University of Melbourne, a public policy expert, a mental health advocate, and deputy chair of the Collaborative Centre for Mental Health. And she was part of the steering committee for the Stigma and Discrimination strategy. And when I heard Maria talking about the strategy at another event, she gave me the idea to have this event. So thank you very much, Maria. And we've got Professor Nicola Reavley. She's the Deputy Director in the Centre for Mental Health and Community Wellbeing at Melbourne School of Population and Global Health, and she's going to talk to us about her research on stigma and discrimination. We've got Erandathie Jayakody, a lived experience expert, advocate and peer support worker who's been involved in mental health law and systemic reform, including as an advisor to the Royal Commission. Dave Peters, who's also a lived experience expert and advocate and co-chair of the Equally Well Alliance. And Dave was also on the steering committee for the Stigma and Discrimination strategy. And Simon Katterl, a mental health advocate and consultant with lived experience of mental distress and trauma, and who was also on the steering committee for the Stigma and Discrimination strategy. So as you can see, they're all very well informed on this topic, and I think we look forward to hearing from them. So if you could put your hands together for our terrific speakers, and I'll hand over to Bernadette. Thank you very much.
Thanks very much, Kay. I hope that I'm coming through loud and clear. I've travelled up from Bunurong country to be with you today, and I also would like to pay respect to elders past, present and emerging. My job is to moderate the panel discussion. I thought that we'd start just with definitions and the scope of what we're talking about today. And I think any time we talk about stigma, we have to go back to the late, great Canadian sociologist Irving Goffman, who wrote the book on the topic. And he said that stigma is an attribute that is deeply discrediting, that it reduces the bearer from a whole and usual person to a tainted, discounted one. That has remained influential as a definition. And the World Health Organization recently defined stigma as a mark of shame, disgrace or disapproval, which results in an individual being rejected, discriminated against and excluded. I have a legal background, so I think that sometimes if we focus so much on the concept of stigma, we might actually be reinforcing this concept of othering, that we are placing the mark of shame in the individual rather than looking at societal reactions and perspectives. So that might be something we can touch on in this panel. as you heard, I was one of the commissioners on the Royal Commission here into Victoria's mental health system. And we made a recommendation directly on this topic. We gave powers to the new Mental Health and Wellbeing Commission here in Victoria to work with networks of others on anti-stigma programs. But we also gave them powers to work and develop different programs that would support legal centres to bring actions against discrimination. And I think that is really important, that it's only by bringing claims that we can kind of move the dial somewhat, because we know that there are discriminatory practices out there in the workplace, in insurance companies and so on. So that's me with my legal hat on, that maybe that's something worth thinking about. What I'm now going to do is to pose 2 questions to each of the speakers, and they have 5 minutes to answer, and I will be keeping time. So I've warned them all beforehand. So the 2 questions are going to be, what's the most important thing that they've discovered in their research or experience or advocacy about stigma and discrimination? But most importantly, what do they see as the priority for reform? We have come a long way. We are prepared to talk much more these days about certain mental health conditions, but the dial may not have gone as far as we want. But we want to look forward. What is the priority for reform? So, Nicola, as the token researcher on the panel, can I begin by asking you, what's the most important thing you've learned with your research, and what's the priority for change?
Thanks very much, Bernadette, for the opportunity. Yes. So that is a good way to introduce, because I have to declare my perspective on this, and I'm a population mental health researcher. So my interest in this is growing the evidence base, and that's around quantifying the scale of the problem and what might work to change it. So I'm definitely bringing that perspective to it. At the end of the day, what I find meaningful is can I contribute to making a difference in people's lives? But that's really what drives me. So there's a couple of things to say in terms of measuring the scale of the problem. I want to do that as rigorously as possible. A lot of work that we've done is around, there's kind of 2 main ways you might think about that at that population level. Measuring attitudes in the population and measuring experiences of people with mental health conditions and what they've experienced. So what we do know from population level research is that, as Bernadette alluded to, we have made some progress. It's probably useful to not to think about stigma as a kind of unidimensional thing. It has different aspects, and we've shifted some attitudes, right? We've probably done quite well on the idea that if you have mild to moderate depression or anxiety, you're weak, you're personally weak, or you could snap out of it. We've probably done quite well on shifting that. We've done much less well on shifting ideas around dangerousness and unpredictability. And we probably haven't really done much at all to shift community attitudes around what we might call complex mental illness. Now, I know terminology is fraught, so that might be less common conditions. That might be people who's are much more impacted in their lives. Whatever term, you want to use for that, probably done much less well. Measuring attitudes is quite easy because you can just do that for anyone. Doing this in a rigorous way often involves not asking people who really care about the subject, because if you put out what we call a convenience sample and say, tell us about stigma and discrimination, there's useful information in that, but what you're not going to get from that is a kind of more accurate population level measurement of the scale of the problem, because the people who are going to answer that survey are going to be people who really care about it. So doing that in that rigorous way does matter and does help us quantify the scale of the problem and change it. Lots of research on attitudes. So in 2014, we did first properly nationally representative survey around experiences. We also actually asked about negative experiences, and we asked about positive experiences, because a lot of stigma and discrimination can be around what not to do, don't do this, don't do that. But you have to give people some things about what they can do, because actually most people are well-meaning, do not want to, do want to help and don't want to discriminate. So we also need to know what's positive and useful. So in most areas of life, the positive does outweigh the negative. We do have some things to build on there. There are some exceptions. Looking for work is another one. Is one of them. So things in the workplace, there's some work that needs to be done there. Picking up also on Bernadette's point around what might need to happen, I think what we might think of as structural stigma, which is those social structures, whether they're in the legal system, in the health system, in the workplace system. I do think that is an area that needs a lot more work and careful evidence building and evaluation. And that in and of itself, but also how that structural stuff interacts with the individual. And we need, our researchers are always going to say we need more research, right? So I'm going to do that. We need much more careful testing of messages and interventions and evaluation, and really, properly looking at what's working, investing in those things, but not investing in what's not working. And that would be my, ideas about how we need to progress this field from that population mental health perspective.
Thank you. That came in within time. You even had another minute. I'm so impressed with that.
Bernadette, if everyone could introduce themselves, because we've had a question saying that people aren't sure who's who.
Oh, right. Okay. Okay, so that was Nicola Reavley, the researcher, the professor from Melbourne University. I'm now going to hand over to Erandathie. Erandathie, did you want to introduce yourself and answer those questions about what have you learned about stigma and discrimination, and what's the priority area for change?
Thanks, Bernadette. Erandathie, I've got a lived experience and have done a whole heap of stuff, and I'm also a lawyer, so I have an interest in mental health law. Look, I do want to pick up on one thing that Nicola said is I think it's important to acknowledge that we have made progress. Sometimes we forget that when all these surveys come out and say, oh my God, all this stigma, discrimination, because I look back to when I was young, when I was 16, when I first came across the system or, experiencing all that distress, there was absolutely no literature around. I mean, Google didn't exist, so that didn't help. There were no flyers. I had no idea who to speak to other than going to the doctor or the psychologist, that kind of clinical system. There was absolutely nowhere to go. And I remember then when I was at university one day, it was at Melbourne University, I was in the female toilets. At the back of the door was this Beyond Blue advertisement about anxiety. I did a double take. I was like, oh my God. Oh, wow. And then I remember at university having to go to ask for special consideration. Took so much effort from my doctor to say, you can go and do that. I was studying law at the time. And I remember the visceral fear of walking in and saying, I'm like, is this going to be on my record? Who'll see this, etc. Because nobody was talking about it. I didn't know how to navigate it. And just another example was I'm first generation migrant. I remember being at a Sri Lankan youth forum and somehow somebody brought up the topic of depression. And that summer I had a really, really bad depressive episode. And I had just come out of it feeling really hopeful about the future. I was going back to university again. And one of the speakers said, oh, look, depression, we don't even have language to describe it. The implication being that it was an invented thing. And I can't possibly describe the heaviness I felt, right? But now I see the kind of conversations happening today, and particularly with young people on social media, despite all its vices, I think there's a lot more awareness that will help people navigate that. And I think it's important to acknowledge that. And it's because of all the work that's happened over the past 20 years or so. I think I'll stop there in terms of, yeah.
And so where do you think is the priority for change? How can we go further? When things have changed, what do we need to do now?
Yeah. So in terms of where do we go next? I want to talk a bit more about the process. So I've worked in the mental health sector now. I've worked with, I'm there's peak bodies, VMEAC, the consumer peak body, Tandem, the carer peak body. You know, there's a lot of other foundations and so on. What I think we're not good at is working together, the idea of collective effort. We're disconnected in how we work. So recently I did this project called Consumers Leading in Governance, and I really wanted to bring in partners that we didn't work with before. So, you know, we had never worked with the Aboriginal Torres Strait Islander Lived Experience Centre, the Victorian Multicultural Commission. You know, I had to go and establish the relationships because there was no organizational relationships. And I think it is so important we do that. And I think as mental health sector, I think broadly, you know, we need to make connections with the Melbourne International Film Festival, comedy. Yes, we do see the topic of mental health coming through those things, but imagine if we had that organizational relationship. Does that make sense? We need to collaborate more at that structural level, right? And going to another thing is asking whose voices aren't at the table. So I was recently at a meeting where, again, a couple of the alliances and the two peak bodies were there, and somebody from a multicultural organization said, oh, I've never heard of VMEAC and Tandem, and they hadn't heard of this organization. And apart from it being very awkward, I just thought, what is it? Is that because we don't, I think we need to make more effort in making connections with those organizations? And also, is it because we don't feel belonged, don't see a sense of belonging because they don't represent us? Because I remember coming to working in the mental health sector, I came in 2012, working as a lived experience worker. And it took me a year or two. I was at the VMEAC conference and there was another brown person, Indian person. And I thought, oh my God, crazy brown person. Let's go and talk to her. And I remember Niharika Hymant being appointed to the National Mental Health Commission. And I reached out to her completely out of the blue because I was so excited. And we got together and, you know, traded war stories, but from a cultural perspective. So, but again, I look and I see a lot of people like me, brown people, sorry, you know, coming through. So that's exciting, but I think we can do more. And how do we build alliances with them? Am I on time?
You are perfectly
Okay,
on time.
great. I had more to say, but
I'll come back to hear a bit more, I think, a bit later. Maria, can I throw to you now? And if you wouldn't mind just introducing yourself, saying a little bit about yourself and answering the two questions.
Thank you. Maria Katsonis. I'm going to speak from multiple perspectives today by way of introduction. First, lived and living experience, an experience that has certainly felt the impact of discrimination and stigma. Also from an intersectional experience, which has contributed to that stigma of someone who is Greek, gay and female. And finally, from a policy wonk perspective, as you heard, I was a member of the National Steering Committee for the Stigma and Discrimination Strategy, and I have been scarred by that experience. And that's probably going to colour my less than optimistic remarks today, because I don't share Erandathie's optimism. Because I think the most important thing that I've learned is that stigma is in its overall sense, whether we think about it, and I'll talk a little bit more about structural, public and self-stigma, is just as prevalent today. We've shifted the dial barely, I would suggest. And I reflect on my own experience as a member of the Greek community when I experienced a catastrophic episode of mental ill health, where mental ill health does not exist in the Greek community, didn't in 2008, still doesn't in 2024. And what that did for me was it really contributed to the worsening of my situation, the worsening of my mental ill health until it was life-threatening, because it perpetuated self-stigma, that deep sense of shame that Bernadette spoke about. But that was caused by that complex, cultural and social factors that don't sit necessarily in structural stigma, where we talk about employment, financial services, but sit more, and this is some of the work that we did in the on the national strategy in public community / stigma, those kind of attitudes. The research that we did for that strategy showed that some of the data that we have today is still as concerning as it was 5 years ago, when 3 out of 5 people with lived and living experience have experienced discrimination. For 1 in 3, that's in the workforce, and more concerning, for 1 in 3, that's been from family and friends. So I think that the experience and the data and the kind of conversations that we had in the development of that strategy did say that it is still an issue of concern, and something that was recognised by the Productivity Commission in 2022, I think it was, when the Productivity Commission actually recommended the development of a national strategy. So when I think about a priority for reform, there is no one magic silver bullet. It's a really complex issue that requires, above all, a systemic approach. There's only so much that mental health advocates and people like us on the panel can do, because we don't hold the levers. We don't hold the levers when it comes to employment. We don't hold the levers when it comes to education, to the health system, to the financial system, where we see some of those structural impediments in relation to stigma, and more importantly, in relation to discrimination. So from a mental health advocate's point of view, as scarred as I am by my experience of the strategy, I will still continue to advocate. I will still continue to advocate to government in relation to stigma and discrimination, because I do think that they ultimately hold all of those levers. And whatever is done, fundamentally, my last thing about the priority for reform is that we put human rights at the very centre of everything that we do, because ultimately we do talk about stigma as technical concepts, but at the heart of it, we have to remember it's about people who should have the dignity to live a full and meaningful life and not experience any stigma or discrimination. So as scarred as I am, I'm still going to go out there and, go to the barriers, so to speak.
Thank you. Thanks, Maria. Now to Dave, if you wouldn't mind introducing yourself and answering the 2 questions.
Thank you very much. My name is Dave Peters. I am, part of the lived experience movement as well, but, having my own personal experience of accessing and using sort of mental health services. But I guess thinking about what the priority I've learned really in this discussion around stigma and discrimination is the scale and scope and the consequence and the impact of that stigma and discrimination. In the national stigma strategy work, my I wouldn't call it an area of expertise, but my focus was thinking about mainstream health systems, and with that came the overwhelming data that is really hard to hear and hard to say. And that's that about 30 people a day of people who access Medicare and pharmaceutical-related mental health treatments are dying from preventable or potentially preventable physical health causes. That kind of disparity, we're talking about 22% of the population in any one year accesses mental health services or treatments. And of all of the people who in Australia die before their life expectancy, mental health, people who have accessed those, that 22% make up 49% of the total deaths that could have been prevented if equal and appropriate access to social and healthcare was available. And that's that bottom lining for me was devastating. It the scale of the problem is overwhelming. And it's not as though the systems and the government and the people who work in these systems aren't all capable of responding. It often comes down to long-held sort of personal attitudes and values. Sometimes it's an approach thing. Sometimes, very often, it's a time and resources issue. Recent survey done by Lived Experience Australia showed that of the people surveyed, 4 out of 5 people had never been asked about their physical health. And I can't think of a more real-world example of stigma and discrimination than the devastating impact of all these lost lives that could potentially be saved if systems were equal and if society was fair and supports were equally available to people. So, hard to sort of go on from that, but thinking about, I guess, what I would choose to be a priority for change would be, I guess, we can do what we can to advocate for government. We can do what we can to advocate for system change. Those things take time, and we have seen some change happen since this has been focused on, and since the awareness and scale of the problem has been sort of pushed to the various jurisdictions. And that's really encouraging. But it's really about trying to impart a sense of personal responsibility on everyone. And that comes as a service user or patient or you know, customer or consumer, but also on the people who work within services. It's kind of having the awareness and willingness to push back against, oh, I don't have time, someone else will pick up on that. That's someone else's role. That'll be picked up in the general screening. Well, actually, maybe it won't be. What can I do within my role to actually try and make a difference for this person? Is it as simple as asking the question, you know, has anyone talked to you about the impact of accessing these treatments? Has anyone talked to you about the impact of taking this medication? If we're forcing you to take this medication by law, are you aware of your rights? They seem a little bit simplistic, but I think that they're things that anyone can do. And often it's if we get enough people on board to actually ask the question and spend the time and energy in potentially opening up a sort of a bit of a can of worms of things that might need to be addressed, it's going to change. Things are going to change. And I hope that's what we can focus on.
Right. Thank you. Thanks for ending on that hopeful note to those staggering figures. Last but not least, if I can throw over to Simon to introduce himself and to answer the two questions.
Yeah, thank you. My name's Simon Katterl, he, him pronouns, and privileged as always to be on Wurundjeri country. It's funny, my phone went flat, so I've got no notes. So I'm going to be super loose, which is more exciting in a way. You know, I was hearing Erandathie introduce herself, and it sort of maybe not having notes lets me introduce myself differently. I think when I think about stigma and discrimination, I think about on a personal level. I remember a particular moment where I was it was in the midst of a mental health crisis myself, and I remember being on a bus and had sort of been so ensconced in my thoughts, and then realizing after 5 minutes that I'd just been, you know, talking out loud and, you know, sort of in my own terms, I wouldn't describe others this way, but ranting and raving, and it was a really complex feeling of shame of where I had to, you know, I had my own experience that was confronting the attitudes I had about those behaviours as well. So it was a very complex kind of experience to go through and process. That, you know, those kinds of experiences, and also, you know, in work with the Royal Commission, working at some of the mental health commissions, and doing a lot of work around human rights. I guess it was, I was nervous when you introduced the Irving Goffman definition, but then you allayed my nervousness by critiquing it, because I think that's a really important critique to have. So when we talk about what's the things that matter most, you know, I think really we've got to be clear on what the problem is and what the vision is of where we want to get to. And I think when we think about the problem in mental health and stigma and discrimination, I really don't think it's that useful to focus on attributes. I think it's better to focus on the social and political order that maintains inequalities between groups. And those inequalities are at the disadvantage of some groups and to the benefit of other groups. And that's the only way that it sustains itself, is that it, you know, that there's an incentive structure to keep it that way. And so when I think about that, I think of like Maria spoke about human rights as being human rights abuses, and that's not, it is in the mental health system first and foremost, but it's also in failure to uphold, you know, equal health outcomes, the right to life. It's in social policy that disadvantages and causes mental distress by state and Commonwealth governments. It's also a failure to uphold dignity and a dignified life as well. And that's, you know, I think a more expansive notion of mental health stigma and discrimination. And it's also just about fairness as well. Many of our systems don't operate fairly, and they operate most unfairly for people with lived experience. And so I think that's a problem. You know, the vision of where we want to get to, I hope, is something, you know, grounded in human rights, dignity, and fairness, and reconfiguring a new social and political order where it's more equitable and fair and grounded in human rights, which it currently isn't. Well, you know, what's the kind of policy ask or direction? Look, I think we focus on issues rather than institutions too much. And so when we talk, I think it's really important to highlight structural change. I don't think we can get change around these issues without change in our mental health commissions at either a state or Commonwealth level. You know, they hold many of the levers, or they can influence many of the levers. And many of the issues that we have arise from the fact that they're not operating effectively, or they're operating to a set of interests that reinforce the social and political order rather than challenge that social and political order. So that's something that we need to grapple with. And, you know, I think we see that, you know, I'm sure people will sort of go into unconsciousness, as I say, as they've heard me say this for a thousand times. But you know, we've got a commission here in Victoria that has had 16,700 complaints about human rights abuses in the services here, and here, and has never issued a single compliance notice across those 10 years. And what does that communicate about, you know, human rights and the social and political order? You know, we had work cover changes here in Victoria 6 months ago that very explicitly discriminated against people with lived experience, and we did not see the Mental Health Commission come out when their role is to challenge stigma and discrimination. You know, we've got a government that is walking away from 74 of the Royal Commission recommendations here in Victoria, and we're not seeing adequate response from the Commission to this point. So I think we can do our individual work, but part of our work needs to make sure the key institutions, and our commissions are one of those, do the work because they've got the levers and resources to do so.
Thank you very much, Simon. And just on that point, you can see the legal background coming to the fore there, but under our Equal Opportunity Act in Victoria, it is unlawful to discriminate on the basis of disability, and that's defined to include, and I quote, a mental or psychological disease or disorder in certain settings, including healthcare, employment and schools. So I put that out there that that is the law. It is unlawful to discriminate. Thanks everyone for coming along today and also for viewing online. We really appreciate it. We have barely scratched the surface. We have a long way to go, but you've heard from some wonderful experts in the field, and hopefully this will continue the conversation. So would you please join me in thanking Nicola, Reavley, Erandathie, Jayakody, Maria Katsonis, Dave Peters and Simon Katterl. And thanks very much to Dr. Kay Wilson also for arranging this on behalf of the Disability Law Network. Thanks, Kay.